Hello, welcome my dear students. Our topic for presentation today is motor disorders of the esophagus. Why are these motor disorders of esophagus so important? This is because what happens is that motor disorders of esophagus generally presents with dysphagia. So when we hear about dysphagia, we think about carcinoma esophagus, we think about any other obstruction in the pharynx, like that. We generally never think about the physiological dysfunction. We think about thyroid. In Kerala, many times people think about thyroid when patients first say about dysphagia and look into their thyroid. This generally happens, and not a proper evaluation is not done in motor disorders of esophagus many a time. So let us have an outlook into the motor disorders of esophagus. Let us know how to evaluate it. Let us understand the motor function of the esophagus properly. So, how does the esophagus function? What is the motor part of it? You see, the peristalsis in the esophagus starts from the cricopharyngeal sphincter. It goes down to the body of the esophagus into the lower esophageal sphincter, and the lower esophageal sphincter relaxes. This is what happens. When this happens, in order to remove the secretions, in order to empty the normal secretions of the esophagus, it is called primary esophageal contraction. When this happens, when the same thing of passage of food from the from the passage of peristalsis from the cricopharyngeal sphincter through the esophagus into the lower esophageal sphincter, the sphincter relaxes. During the swallow, during intake of food, it is called a secondary contraction of the esophagus. So, primary contraction of the esophagus, secondary contraction of the esophagus. There is also another entity called tertiary contraction of the esophagus. We will come to it. Before going any further, we should know the basic investigations how which the motor disorders are being worked up. One is manometry, another is esophagogram. Esophagogram, we know it is a barium swallow. By intake of barium, and you take an X-ray, you see the picture and you find whether there is any anatomical abnormality along with it. But the physiological anomaly is better delineated in a manometry. In manometry, let us just see this picture and understand it. Discussing much about the manometry is beyond the scope of this presentation. See, in manometry, the blue color is of lower pressure, the green color is a bit more higher pressure, the yellow is a bit more higher pressure, and the red is the maximum amount of pressure. You can see the upper band. The upper band of that red-yellow part is the cricopharyngeal sphincter. The cricopharyngeal sphincter is in a tonic contraction phase. Only during the passage of the foot, the cricopharyngeal sphincter relaxes. And you can see in the lower part also that there is a greenish coloration. That is the lower esophageal sphincter. Prima facie itself, we can understand that the lower esophageal sphincter tone is comparatively less when compared to the upper esophageal sphincter. And you can also see the esophageal peristalsis. You can see the peristaltic wave passing through the esophagus. That is regarding the manometry. Now coming to the motor disorders. Motor disorders of the esophagus can be classified into primary motor disorders and secondary motor disorders. In primary motor disorders, the problem is in the esophagus itself. Let us say the problem is in the esophageal musculature of the body, or the esophageal musculature in the sphincter, etc. Whereas in secondary motor disorder, it is a problem somewhere else, like connective tissue disorders causing an esophageal anomaly, connective tissue disorders causing a muscle defect, muscle problem. All these are secondary motor disorders. In primary motor disorders, the anomaly is in the esophagus. The motor disorders of the primary motor disorders of esophagus are classified basically into 5. They are Achalasia cardia, diffuse esophageal spasm, hypertensive lower esophageal sphincter, Nutcracker esophagus, and ineffective esophageal motility. Now, coming to Achalasia cardia. Achalasia cardia is due to the destruction of the nerves of the lower esophageal sphincter plus the degeneration of the neuromuscular function of the body of the esophagus. So, in Achalasia cardia, there are two parts. Lower esophageal sphincter, destruction of nerve, results in the tonic contraction of the lower esophageal sphincter. The lower esophageal sphincter fails to relax. and in the body there is a degeneration of neuromuscular function, and as a result the effectiveness of peristalsis will not be normal in the body, or the peristalsis will not be as strong enough, and the esophagus will also get dilated. There is another entity known as vigorous achalasia. In vigorous achalasia, what happens is the esophageal sphincter is like the lower esophageal sphincter is abnormal as in achalasia cardia, but the body is normal. The peristaltic wave is normal. Now, the achalasia cardia is not only that it is a problem with the physiological function, it is a pre-malignant condition also. And the most common malignancy which is seen in achalasia cardia is squamous cell carcinoma. Let us see the function of let us see what happens in achalasia cardia. You see the peristalsis in the esophageal body is of a lesser powerful than the normal esophageal peristalsis. And you can see the sphincter does not relax when the peristalsis comes in the lower esophageal sphincter. In case of vigorous achalasia cardia, the peristalsis is normal, or maybe a bit more high due to there is a bit more spasm in the peristalsis due to the contraction of the lower esophageal sphincter, due to the non-relaxation of the lower esophageal sphincter. But that is happening in vigorous achalasia cardia. How does the patient presents with achalasia cardia? There will be dysphagia, regurgitation, and weight loss. Because many a times this dysphagia and weight loss is welcomed by the patient, because the patient is losing weight and the patient is happy many a times. So sometimes the patient will not present initially as dysphagia. And you can see that the dysphagia is more to the liquids than to salt, so that he can eat meal many a times. The patient will surely present when there is pneumonia, lung abscess, and bronchiectasis. There is, due to the vigorous achalasia cardia, due to the contraction of the lower esophageal sphincter, the food is not able to pass and the food is regurgitated, and during regurgitation there is aspiration into the trachea, aspiration into the trachea, which results in pneumonia, lung abscess, and bronchiectasis. We will initially do an esophagogram, and the esophagogram may show an appearance like this, especially in long-standing cases. There is a bird beak appearance and the lower esophageal sphincter due to the tonic contraction of the lower esophageal sphincter, and you can see the esophagus is dilated. It is called sigmoid esophagus. The esophagus is dilated, and maybe sometimes it can be really dilated and tortuous and S-shaped. And there is, due to the decreased passage of air into the funding gas shadow, there will be lack of gastric air bubble in abdominal X-ray. It is not shown in this picture. Now, manometry is the gold standard in case of achalasia cardia. We can see the lower esophageal sphincter tone is high and the esophageal peristalsis is of a lesser pressure in case of achalasia cardia. Now, the medical management of achalasia cardia include sublingual nitroglycerin, calcium channel blockers, and nitrates. That is a medical management. Now, in case of a lower esophageal sphincter not at all relaxing, we can go in for a bougie dilatation. Generally, the bougie of 54 French is used. Initially, you can see in that picture, initially a guide wire is passed. How we pass the bougie through a structure? Initially, a guide wire is passed, then a small bougie is passed, removed, and over the guide wire again a larger bougie is passed, removed, again a larger bougie is passed, and at least a 54 French dilatation will be required for effective passage of food into the esophagus. This is another type of dilator. This is a balloon dilator, a Grunzig type of balloon dilator. In that, we can see that balloon. The balloon is kept at the point of lower esophageal sphincter, and the balloon is inflated with the pressure, with the help of the pressure monitor, so that we can monitor the pressure. And when the balloon is inflated, it dilates the lower esophageal sphincter. What is achalasia cardia? Achalasia cardia is due to the non-relaxation of lower esophageal sphincter. So, botulinum toxin is given in order to relax the lower esophageal sphincter by passing endoscopically. Is there any role of surgical management? Yes, surgical esophagomyotomy is the treatment of, many times the treatment of choice in achalasia cardia. Laparoscopic Heller's, it is also called laparoscopic Heller's myotomy. In that, you can see in that myotomy, the incision is started at approximately around 2 cm above the lower esophageal sphincter, and it is passed around 2 to 5 cm below. And the lower esophageal sphincter is cut, and the lower esophageal sphincter is cut up to the mucosa, and the sphincter is so that the sphincter tone is lost, so sphincter tone is decreased. So what happens after the surgery? The patient can have a gastroesophageal reflux disease. In order to prevent this gastroesophageal reflux disease, many a times a fundoplication is done along with Achalasia cardia. You can see in this picture a two-pay fundoplication is done after Heller's laparoscopic Heller's myotomy. Now, coming to the next disorder, diffuse esophageal spasm. Diffuse esophageal spasm is due to the muscular hypertrophy and degeneration of the vagus. The complete pathophysiology is not fully understood as far as the diffuse esophageal spasm is concerned. It generally affects the lower two-thirds of the esophagus. The patient's general presentation of the patient is chest pain and dysphagia. Women are more affected than men. Now, here comes this is due to the tertiary. What is diffuse esophageal spasm? Diffuse esophageal spasm is classically the tertiary contraction of the esophagus. You can see in secondary contraction of esophagus. Secondary contraction of esophagus is like pressing a toothpaste. When the toothpaste comes out, when there is esophageal peristalsis, the lower esophageal sphincter relaxes and there is progression of food in the esophagus. But in case of a tertiary contraction of the esophagus or in case of a diffuse esophageal spasm, the contractions in the esophagus are in multiple sites. It does not there is no adequate progression, and there is may or may not be a sphincter relaxation, a lower esophageal sphincter relaxation associated with the peristalsis. That will be depending upon whether the peristalsis reaches the lower esophageal sphincter or not. Lower esophageal sphincter will be functionally and physiologically normal, but the contractions in the body of the esophagus will be erratic and multiple. That is regarding the diffuse esophageal spasm. Now, this is the picture, esophagogram picture in diffuse esophageal spasm. You can classically see a corkscrew appearance. It is also called a pseudo-diverticulosis. Pseudo-diverticulosis appearance. Now, the treatment of diffuse esophageal spasm is mainly non-surgical, and in some cases you can go for surgical management. Non-surgical management includes the sublingual nitrates, calcium channel blockers, nitroglycerin, etc. And the surgical management includes a long segment esophagomyotomy. What happens is a long segment of esophagus muscle is cut where the diffuse esophageal spasm is maximally affecting. This is generally done when there is a true diverticulosis due to the diffuse esophageal spasm. You can see the picture of diffuse esophageal spasm. There is a multiple contraction sites at the esophagus. The lower esophageal sphincter is normal. Now, the next pathology is a Nutcracker esophagus. That is a classical Nutcracker. You can see in Nutcracker esophagus is the most common and the most painful disorders. Patients generally present as odynophagia. What is classically Nutcracker esophagus? It is a high amplitude peristaltic contraction. It is like pressing the toothpaste with a heavy rod or something. The contraction is a normal contraction. The contraction is normal. The chronicity and progression of the contraction is normal, but the amplitude of the contraction is very high. That is seen in Nutcracker esophagus. The medical management, the primary management of Nutcracker esophagus is medical to avoid triggers. The triggers normally the increased contraction of the esophagus is stimulated by caffeine, hot or cold foods. So, in order to avoiding the triggers, calcium channel blockers and nitrates are the medical management. In conservative management, we can also use Buji dilatation in case of a strictures, in case the dysphagia is progressive or there is strictures, and there is lesser, the surgical management has lesser role in Nutcracker esophagus. You can see here the Nutcracker esophagus, the contraction in the esophagus is of a higher amplitude and peristalsis, but it is progressive, and the lower esophageal sphincter relaxes normally. The normal contraction is set, but it is of a higher amplitude. Now, next is hypertensive lower esophageal sphincter. In hypertensive lower esophageal sphincter, the patient presents with chest pain and dysphagia. You can see the lower esophageal sphincter pressure is above the normal, but there will be normal relaxation. It means that when the peristalsis comes, it comes down and the sphincter will relax. But the tone of the sphincter, lower esophageal sphincter is very high. So it will take some time to relax, and the patient will present with a similar symptoms to Achalasia cardia. Patient can present with chest pain and dysphagia. The treatment is again similar to Achalasia cardia, botulinum toxin, balloon dilatation, and in some certain intractable cases, Heller's cardiomyotomy is also done. You can see the contraction goes down to the esophagus, goes down, it reaches the sphincter. Sphincter, due to the increased tone of the sphincter relaxes, but it will take some time to relax. Next is ineffective esophageal motility. Ineffective esophageal motility is a contraction anomaly of the distal esophagus as a part of gastroesophageal reflux disease. What has happened there is in the distal, due to the increased amount of gastroesophageal reflux disease like that, there is dampened motility in the lower part of the esophagus. The muscles get affected. The patient presents with heartburn, chest pain, and regurgitation. What you have to do is there is not much of treatment in case of ineffective esophageal motility. So prevention is better than cure in ineffective esophageal motility by proper management, early identification of gastroesophageal reflux disorder, and proper management of GRD. Now, this is you can see the ineffective esophageal motility in the lower two-thirds of esophagus, but the sphincter will be normal. Next is non-specific esophageal motility disorder. The non-specific esophageal motility disorders are generally secondary. Secondary means this is not a primary. When we see a non-specific esophageal motility, when we understand that it is a non-specific esophageal motility disorder, the esophageal manometry doesn't show any of the classical features. The esophageal manometry picture doesn't fit into any of the above 5 of Achalasia, cardia, ineffective esophageal motility, hypertensive lower esophageal sphincter, diffuse esophageal spasm, or and diffuse esophageal spasm. So it doesn't fit into any of these 5 categories. So then it is called a non-specific esophageal motility disorder. This is generally a secondary disorder. It generally happens in relation to the collagen vascular disease, and the classical feature is poor esophageal motility, which doesn't fit into any of the above 5. So that is what we have discussed regarding the motor disorders of the esophagus. This is the outline of motor disorders of the esophagus. You should know about the primary motor disorders, the 5 types of primary motor disorders, how to investigate them with manometry and esophagogram, the secondary motor disorders, and how to treat the primary disorder in case of the secondary motor disorders. With that, let us conclude. Thank you.